Hello, everyone. Welcome to our topic today for LGBTQ plus health and HIV testing roundtable. I'm Dr. Rodriguez. I'm a family medicine doctor and HIV specialist. I'm the medical director at Spectrum Medical Care Center. I've been involved with HIV since residency, and my career goal has always been ending the HIV epidemic. At Spectrum, I'm proud that we've been trying to break barriers for HIV testing, treatment, and prevention. Currently, we have a one-of-a-kind mobile clinic unit that we've launched last year, which we call the PrEP Mobile. With this PrEP Mobile, we'll go out to the community and provide sexual health, HIV testing, treatment, and prevention. And for people that need PrEP, we are able to provide same-day PrEP free of cost for 30 days. This has helped a lot to our community, especially for those people that are not able to go into a conventional clinic to access PrEP. Last month in May, we were able to start 50 people on PrEP, which is something really good. Next week, it is June 27th, is the National HIV Testing Day. This day is to bring awareness on providing HIV testing, especially for those communities that unfortunately the rates are low, which is within the LGBTQ plus and the Hispanic community. I'm happy to be presenting this, being the moderator for this talk with 3 experts on this topics. I'll present them and then I'll give them a little bit time for them to talk about what they do. So first we have Dr. Carina Marquez. She is the Associate Professor of Medicine from UCSF. Also, we have Leo Sheridan. He's the Capacity Builder for HealthHIV. And then we have Dr. Franco Chevalier. He's the Deputy Medical Director at San Francisco City Clinic in California. So Dr. Marquez, do you want to start first?
Yes, so it's such a pleasure to be here on the panel with all of you. Thank you for the nice introduction. I am an infectious disease physician and researcher. I take care of patients at Ward 86 at San Francisco General Hospital, which is our county HIV clinic. And within that, run the Salud Clinic, which is a multidisciplinary clinic that focuses on monolingual Spanish speakers and really providing multidisciplinary care for our patients. I think our clinic has a lot of really innovative programs from a pop-up clinic where we do wraparound services and care for patients who are marginally housed. We have a very large, long-acting ART program as well as PrEP program, and then have recently been participating in a citywide health access program where we have drop-in sexual health services where you don't need an appointment, you don't need insurance, you just show up and we provide services. So that's some of the clinic-based services I'm involved in. In addition to that, I am also a co-founder of the Unidos en Salud collaboration, which is a community academic partnership that we formed with UCSF, partnership UCSF, SFDPH, and the Latino Task Force, which is a coalition of CBOs. And that was actually formed during COVID to really provide low barrier community-based access to COVID treatment, vaccinations, and testing. And then has since then really blossomed and to provide multi-disease testing, diabetes, HIV testing, and thinking about novel strategies to increase HIV testing in the community, specifically for Latino population. So that's a little bit about me and looking forward to sharing more.
Thank you, Dr. Marquez. Leo, do you want to go next?
Yes, thank you. Super happy to be here with everyone. My name is Leo Sheridan. I'm the Capacity Building Assistance Manager at HealthHIV. So I essentially run a good portion of our capacity building programs. These programs educate clinicians, doctors, community healthcare workers on everything from HIVs, STIs, and drug user health. We also run a couple of micro grantee programs where through grants, we give additional funds out to smaller nonprofit organizations here in the DC, Maryland, and Virginia area who are also at the forefront, boots on the ground, dealing with the epidemic here in the district region. Before this position, I was client-facing, working at a clinic in DC called Us Helping Us, where I assisted in HIV testing, linkage to care, and harm reduction efforts. We also had a mobile unit, so I was very much boots on the ground and really linking people to care right on the streets where a lot of them, were living. So just super happy to be here and lend my expertise to this discussion.
Thank you, Leo. Dr. Chevalier, you're next.
All right, thank you. Hi, everyone. My name is Franco, and it's also a pleasure to be here. It's almost like a full circle moment having Dr. Marquez here. As Dr. Marquez, I'm also an infectious disease doctor, trained at UCSF, and it's kind of bittersweet to see Dr. Marquez here because we collaborated in a lot of projects. She was a mentor for me in many ways, and we still stay in touch in many ways. And both of us also serve as HIV providers at Ward 86, which is where she also works as well. But currently, the big hat that I wear now is Deputy Medical Director for the Department of Public Health Municipal Sexual Health Clinic, known as San Francisco City Clinic, which essentially is an all-inclusive sexual health sort of bundle care for all San Franciscans, regardless and irrespectively of documentation, irrespectively of insurance status, irrespectively of housing status, or financial status, or anything of that sort. And so essentially, we extend our services to anyone that sort of steps into our doors. And when it comes to providing services, one of the things that we sort of pride ourselves in is obviously providing high-level quality sexual health care when it comes to STI screenings, as well as HIV screenings, and also testing and treatment and prevention. As a matter of fact, we have over 1,000 people right now that are currently on PrEP. And we do offer all sort of PrEP modalities, from like oral PrEP to injectables. We diagnose a large proportion of the HIV cases here in the city of San Francisco as well. And we also collaborate every time that we have a new HIV diagnosis or anyone that's out of care living with HIV and have no access to medication, to be able to make sure that they start on medication, that they get connected to care, and that they're able to sort of have that long-term follow-up with a provider as well. But outside of that, we sort of try to approach things from a syndemic perspective, always kind of keeping into perspective the sort of the STDs and sort of how that sort of correlates with HIV as well. And so with that as well, we offer doxypep, we offer all kinds of different strategies and counseling around how to prevent those kinds of things as well. And, with that also family planning. And so there's a lot to sort of discuss when it comes to HIV and everything else that sort of embodies all of that. And so really happy to answer any questions and sort of dive deeper in that today. Thank you.
All right, thank you for the three of you. So yeah, June 27th, National HIV Testing Day. So this is a day that, it's to emphasize that awareness of HIV test and for people to take control of their sexual health. Leo, in your experience, what are some missed opportunities that clinicians, are able or have to promote this HIV testing, especially under underrepresented communities like the LGBTQ plus or Latino population?
Oh, so many missed opportunities. I could probably go on and on for days, but I'll try to keep it short. Honestly, something that I'm still seeing in the work that I do is the miseducation of a lot of college and high school students. There are populations there that are just getting into kind of their sexual experiences, just getting into their, that exploratory behavior. And a lot of them are coming from school systems that did not educate them on just basic sexual health, basic safety, basic harm reduction, and things of that nature. So I really think initiating programs, across the board at the college level and younger, especially when it comes to, National HIV Testing Day, is definitely going to weed out a lot of the issues that we see much later on when it comes to HIV, STIs, and kind of everything under that umbrella. Hit them where they're young, I think is something that's really, really important, and that definitely I think is still a missed opportunity.
Thank you, Leo. Dr. Marquez, as a family doctor, I see a patient and I have to address a lot of things. What will be something that I can do to integrate that HIV test during my visit when they're coming in for diabetes, hypertension, and a lot of things that they just want to talk about?
Yeah, this is, we're always so pressed for time, and there's so many different things we're trying to address in our primary care visit. So I think just really trying to make just as we make sending screening for hemoglobin A1C, really integrating HIV testing into that routine conversation. So sometimes I'll be like, we're gonna check your hemoglobin A1C, it's test for diabetes, with everybody. And I try to really normalize HIV testing for everyone and have this opportunity to just say, I talk about this with all my patients, we screen for HIV, X amount of time. So really just integrating it into the routine. It can sometimes be a quick conversation, or taking time to say, address what are your sexual health goals, or, really weaving that into the regular conversation, I think, is key. Or sometimes I'll just drop a quick comment. Have you heard that there's a new medication that can prevent HIV? And then that sometimes, a lot of times, people haven't really heard much about PrEP, and that's a really nice way to quickly integrate discussions about PrEP and HIV testing into conversation. So I think integrating it just like A1C and blood pressure screening, and it can be quite quick, and into just routine, regular testing. So it's one approach.
Thank you, Dr. Marquez. Dr. Chevalier, as a Latino, I come in, especially, let's say I immigrated here, and you tell me about the HIV test, and I'm scared. I'm like, oh no, I don't want that because I don't know what I'm going to do with that result. What are some best practices that you integrate in your clinic, helping having that conversation with patients?
Yeah, no, that's a great question, and it's one that I feel like I encounter a lot here, especially in this setting at the sexual health clinic, where we have individuals from all sorts of walks of life, members of the LGBTQ community, just as we have individuals that may be married and may have had, say, an affair, or someone that was under the influence of X substance, and for whatever reason they feel compelled to come in and get an HIV test, but don't want to sort of like face the fear of potentially having a positive result. And I think kind of thinking about the missed opportunities and the conversations that Dr. Marquez was saying, and sort of like making it part of the sort of like the bundle of preventive care. I think first and foremost is sort of fostering an environment that's stigma-free, and that is and very deeply rooted in like a sex-positive environment, where I think that all is welcome. There is a spectrum of sort of diversity when it comes to like sexual health, and when it comes to like the knowledge that people have around HIV, and also just getting tested in general. And as they were talking, I was just writing here, I think that the messaging that goes out from us providers really has an impact on patients. And so if you come from a stigmatizing or judgmental place of like, you need to get tested because, if you have HIV, X, Y, and Z, but rather than doing that, sort of turning the narrative of like, sexual health is part of preventive care. And, it is recommended that anyone that, that is having sex without a condom, with multiple partners, or at least more than one partner, should get at least regularly tested. And depending on your risk factors, that frequency may vary, maybe once a year, maybe every 3 months if you're on PrEP, et cetera. And sort of just normalizing those conversations and making it part of your routine, to just kind of not just saying it verbally, but also from the messaging that's on the office and in the waiting rooms, from the messaging that goes out in the commercials and in the community. And so I think that doing all of that all together really just fosters that comfortable environment for people to just kind of be open and not feel so pressured and scared to sort of come in and get tested.
Thank you. And Dr. Marquez, anything you want to add, or anything especially on your experience with any patient recently about that?
Yeah, I think this really welcoming environment in the clinic space is so important, and the normalizing is key. And I always have remind people, like, especially when patients are scared, or they kind of are a little bit hesitant to do, or they don't want to know their size, like sometimes we have to remember to bring it up. So I have a lot of patients, who may not bring it up. And then when I ask, they're like, okay, are you sure? It's just this opportunity to ask questions. And so, especially when you're in this trusted environment, I think I haven't it's been a very rare circumstance where people have said no, but when I brought it up. And then I spend a lot of time actually through our community testing programs, sitting in community and talking about PrEP and people, or HIV testing, and people, sometimes there's an initial hesitation, but if you bring it up, I think people are ready to bring their questions forward. And I think people are coming into it, especially as, when I'm talking to people who have recently immigrated, you may have different levels of awareness about what services you can access within your city, what's free, how do you get free HIV testing, that you can access PrEP, and how to navigate that. And so I think, in addition, I encourage us providers to also continue, seek out opportunities to be in the community, because I think a lot of people trust clinicians and us being there in community to engage with people who haven't really connected with our health system or primary care is also a key piece of this, just like the mobile clinics, which I think you probably had a lot of experience there.
Yes, and definitely, having the patients that come into the clinic, I think it's a more controlled environment. It's easier for us to provide that test, right? But we know a lot of people do not go into the clinic. So that's where we have to create those non-conventional approaches. And in 2023, CDC came out with this initiative of self-testing kits that are delivered home, which is Together, Take Me Home. Leo, is there more options or other ways to do HIV testing in other like non-clinical settings that you know or are aware of?
Absolutely, and it's interesting that you just brought up the self-testing, because I've worked on a program here where individuals can get these tests mailed to their homes, and they can, do it in the privacy of their own home. It's packed full of resources, whether they have a reactive test or not, and it puts them in a position to have their health in their hands, which is really, really important. And not only are we pushing and advertising this program to individuals that want to know their status, but it's also important that social workers have access to this. Teachers, school nurses, there are a lot of mediums where people go for help that might not look as clinical as we would like them to be, and who decides what a mentor looks like. It could be a neighbor, a friend, a school counselor. So we're really pushing this program so that people can order these tests, do it in the comfort of their own environment, have the resources that they need, and then get linked to care, when they're ready to do so, whatever that care might look like.
Okay, thank you, Leo. And to continue with the conversation, actually at Spectrum, we did have this program for sending these self kits to home, but we had to pause it because our return rate was really low. It was less than 1%. So any best practices or anything that, let's say for my clinic or any other clinic, or if they want to implement this program, what are like best approaches or any best practices that you might suggest?
So honestly, the program here has been seeing great numbers. I don't have them in front of me, but it's been super aggressive in the sense of where we're advertising. And I think that's where it kind of comes down to it. So it's high school and college campuses. It's clinics that individuals may walk into. It's with social workers within the city government. But it's also being present at Pride events. It's also being present at women's events. Obviously we're seeing an uptick in Black women, specifically Black and brown women specifically, who want to know their status, want to take their health into their hands. And so we're being present at more events that you may not necessarily see HIV outreach at, perinatal events, right? OBGYN clinics and things of that nature. So I think it's just broadening the spectrum of where, HIV care should be placed, because I think it has a further reach than what a lot of organizations are kind of doing. So it's just thinking outside the box a little bit.
Okay, thank you. And definitely that collective work, I think it's reaching out to other organizations, especially those hard to reach populations that with their clinic you're not able to, but someone is already there. So it's just making that extension. And that's something definitely that has helped. Dr. Marquez, in your experience, have you seen any reductions in health disparities with these self-testing kits?
Yeah, I think I really love the self-test kits, and I think this is an area that we can really grow. I think the CDC program was really fantastic. Leo has really shared some, successes and really sort of decentralizing and really allowing easy access to self-test kits. I think there are a few challenges though with self-test kits. In part, it's, on a programmatic level, it's cost. They're very expensive. And so thinking about, what needs to happen on a policy level to ensure cost lowering and improved access to health, to the self-test kits so that you can make sure there's a nice supply at the school nurse or, or at your local CBO. So I think that will be really helpful. I think other areas where self-test kits have shown, at least on the research world, although I think we're thinking about implementation of this, but really through social networks. So having peer champions or who are handing out self-test kits. And that has been, I think, very successful. There's been great work in terms of, prep mobile clinics and having people who attend the clinics also hand it out to their friends and then refer back. I think one of the kind of key things is for a negative test, making sure we have status neutral linkage. So not just for a positive test, people have resources to go to the clinic for confirmatory testing and services, but also making sure that we're still having that connection in a trusted way and that the people who are handing out test kits are able to really help link for prep. And so I think that's things on the implementation side that people are working on. But overall, I think we saw this with COVID, the uptake of home self-test kits was huge. It's like fast, convenient, and easy, but things like, as we, cost and other things, do impact the, how the implementation of it. And so really exciting potential, something we're really working on. And then also thinking about, home STI test kits as well, have also great potential. And really trying to figure out, we need new tools and try to think about things differently. I know in San Francisco, for example, the number of new HIV among Latinos the new number of new HIV diagnoses is increasing in Latinos and decreasing in everybody else. And so trying to think about other ways to reach populations who aren't, don't have easy access to testing through their health facility or aren't accessing it. So those are a few kind of thoughts.
Thank you. Yeah, definitely cost is a big factor, and partnering with other organizations that will definitely help a lot, and it's something that can help. And then Dr. Chevalier, you did talk about syndemics, and it's syndemics kind of not a new term, but it's been around a little bit. It's just meaning a lot of the epidemics that correlate with each other, and it's something that has been happening with HIV, Hep C, other STI, substance use disorder. When having that sexual education with your patient, how can you empower them for preventive sexual health? What are some best practices that you are currently doing to reduce this endemics?
Yeah, totally. Thank you for that question. I think first it's like important to really think about, I guess, what syndemic really means. I think that it's a term that is sort of coined into thinking about, first of all, how sort of diseases sort of arise or how illnesses and health sort of is impacted. And this is just more about the idea that no disease essentially exists on its own. And there is sort of an interplay and intersectionality that sort of crosses over when we're talking about things like HIV. We do know historically, and we know as clinicians as well, that, if someone has syphilis, if someone has herpes, they're more likely to acquire HIV during that sexual encounter just based on, medical things, risk factors, etc. And so with that in mind, I think that any sort of encounter that a clinician has, or anyone for that matter, with anyone that's seeking HIV testing, should also open the conversation about getting tested for STIs and sort of creating a bundle when it comes to sexual health. And I will go even a step further, which is not only talking about HIV testing and STI testing, but also promoting ways to prevent both of those things, and sort of incorporating, PrEP and things like DoxyPEP, and talking about safe sexual practices, and sort of meeting people where they are, and engaging them in a conversation so that they can sort of come up with a plan of how they seek to prevent STIs or potentially HIV. And so, when we talk about a syndemic approach, we're talking about how can we sort of prevent everything that sort of ties into HIV and prevention, and make people empowered about their sexual health. So to reduce, health to reduce sort of like the poor outcomes that come with STI acquisition, with HIV acquisition, but also just to reduce the burden of STIs that we've seen that has been continually rising globally, but also HIV as well within the Latinx community as well. So yeah.
Okay, thank you. Dr. Marquez, DoxyPEP, an amazing tool to prevent bacterial STIs. In my experience, I've had multiple patients coming in just asking for DoxyPEP. And when trying to do, and they're HIV negative, and when trying to do HIV PrEP, they refuse. Is there some, in your experience, a way to, approach it and try to have them, that unfortunately, because of their sexual practice, they're at risk of HIV. What is a good conversation to have to try to help them be on HIV PrEP?
Sorry, the question was HIV PrEP or DoxyPEP or both?
So they're coming for DoxyPEP, and
DoxyPEP.
they're sure they want to, but they're HIV negative, but they're not
Yes.
interested in HIV PrEP. So
yeah. No, it's great to hear, that people are coming in asking for DoxyPEP, and I've seen that in my panel as well, which is nice, and is great to hear the word is out. I think, with DoxyPEP, you have multiple opportunities to interact with people. So I think that first conversation of talking about HIV PrEP, and understanding sort of really what if they're not interested, trying to understand why. And sometimes I've had a lot, if we're able to offer injectable cabotegravir as PrEP, that sometimes is really exciting. So they're, and just explaining the different methods and options for PrEP versus PEP, injectable versus 211, and really having the conversation to, share the different methods of PrEP and what fits that person's need. If it's not of interest, I think you have multiple times to kind of continue to interact and explore why or why not, and how we can serve them better. And I think people have a variety of different reasons, whether it's, they didn't want to come into the clinic every 2 months for their injection, or they didn't, had side effect from the pill, or they're worried about that. And so trying to figure out how, we're in this great place where we have a lot of different tools for PrEP. And so figuring out what can work for them. So I use both PrEP and DoxyPEP as an opportunity to discuss the other one. And I will just add as a note, patients, I think, are so happy with DoxyPEP. We have a lot of patients who have syphilis multiple times, and now there's finally a tool to help reduce that risk. And it's very, very exciting, and been going well. So excited to have that extra tool.
Thank you. Yeah, definitely in our clinic, we have seen that uptake of DoxyPEP, and also a little bit of reduction on especially chlamydia and syphilis. But especially here in Arizona, congenital syphilis is still on the rise. And I think those are the missed opportunities that we're having for cisgender women that are pregnant. So it's just having that. And Leo, especially when talking about syndemics, and we go out to other communities or to other partners, in your experience, what is the best way to, instead of just being like, hey, here's this HIV test, let's have people address it, what other ways can we create so that way we approach all the sexual health and all the syndemics at the same time?
That's a really, really good question. And it's something that's ever changing, right? So when I think about going out into the community and doing outreach, I think the best way to do that is to find other communities. And when I say that, I mean the faith-based community. So it's an already established group of individuals, under one roof for one thing. Sports communities, intramural sport communities. We've found ways, when I was client-facing, we found ways to kind of kill two birds with one stone. So it wasn't necessarily us, hanging out on a street corner, talking to individuals, though that is a great way to do outreach, but we wanted to build our numbers. So we really focused on already established groups within the community that had a good sitting in the community as well. So their reach extended past their group themselves. And we would do workshops, we would do, capacity building initiatives with them. And that really helped the overall education of that group. And then that group went out and kind of did their own teachings and their own trainings. That honestly is the best way to do it because they're already a trusted entity within their communities. One good example is the soccer community, specifically in Washington, D.C., amongst the Latin population is very, very large. And so we decided to do a lot of workshops with them at a lot of their games or a lot of their food outings. And it was just an easier way to get associated with them, learn who the clinicians were within those groups, learn who the nurses were within those groups, the community health workers, within those groups, and really span across, individuals that might have been very new, to this country, and individuals that might have been, there for decades, and do that cross-cultural exchange of this information. We found it very fruitful in our HIV outreach efforts.
Yeah, that's definitely something helpful, just educating other organizations or partners and the way they're just reaching, they know how to reach that population, and it's just providing those extra services, and it's something really, really good. The stigma. I think stigma plays a big, big factor in HIV and STI testing, and especially when people go into a clinic. Dr. Chevalier, what's some ways that you can, provide that inclusive space for someone to go in and actually promote and feel like, hey, I want to do an HIV test. I want to know my status. What are some things that I can change in my clinic to have that inclusive space?
Yeah, that's a great question. And I think one that we continuously sort of think about in the context of sexual health and providing care here. I think for me specifically, I always try to approach it from the perspective of, sort of thinking back all the way to sort of like the sex talk with my parents, so to speak, and say, how would you approach that conversation? How would you approach that conversation with a friend or with a colleague or someone that you were generally concerned for? Because I think that it really just grounds you into thinking about someone that's in front of you as a human being and as someone that just like you could be vulnerable due to how they not know the right information or receive the right information in the time that you have with them. And so, really thinking about that, this could be the only time that you have or that this particular individual may have to actually have a sort of clinician facing encounter where they can actually talk about their health. I think that's the first thing that you should sort of have. And then the second thing is, I think it's just normalizing taking a sexual health history. I think a lot of times as providers, it could be very easy to sort of shy away from all the details and the specific things that we have to ask when it comes to that, but really understanding how people identify, how people sort of, engage in sexual practices, what type of things do they do, what kind of behaviors are they seeking, what type of genders, what type of risk factors, what are there substances, or do they do this, do they do that, and really going deep into that. I've actually encountered many patients where they're like, man, like you guys ask way too many questions and it's almost like, too invasive. But I let them know, I think it's part of the work in the sense saying like, in some ways, this allows me to sort of help you because it does provide sort of it opens the door for me to be able to introduce strategies for prevention. And so a lot of patients really tend to appreciate how detailed we really go in terms of like their sexual practices, from whether condoms were used or not, how many partners and when was the last time they were sexually active, do they know if the person that they had last sex with was HIV positive or undetectable, or if they are on PrEP, or if they're injecting drugs and things of that nature. And then the last thing after that is just always making yourself really available, because I think that a lot of times we may encounter resistance and patients may not be comfortable opening up the first time around, but also just kind of providing that feedback that, hey, this may not be the perfect time, or this may not be the time that you want to talk about this, but if you are willing or able or want to really have a conversation or ever have questions, feel free to come in, feel free to reach out, and always keeping that open door policy, because people will come in eventually when they're ready. And so understanding that just because you want to save everybody you cannot do it all the time, but also just allowing them to really come to terms with that and to come in when they're ready. I think that's really the most important thing, because, I think that a lot of times we miss the opportunity thinking, they'll never come back, and dismiss it. So.
Yeah, definitely meeting where they're at and building the report later on. And it's something, and not just for sexual health, I think also for like substance use disorder, tobacco, all that. We need to be, take our time and just be with them whenever they're ready for to having that. And then also another barrier that we've encountered is language. So Dr. Marquez, especially when we have a huge Latino population, what are some ways that we can create that environment where it's an inclusive language? And have you seen that that helps with the rates of HIV testing or STI testing?
Absolutely. I think language is so key. And I think within our clinical space, we've really tried to make sure that we have language concordant providers and a language concordant experience throughout the whole experience. So our front desk staff speaks Spanish, the medical assistants taking the vitals speak Spanish, your provider speaks Spanish, the case managers and the social workers and the nurse speak Spanish. And I think language is really a key part of feeling comfortable, having this inclusive environment. For places that cannot, do not have that capacity, I think ensuring good interpreter, services is critical. So we've really tried to work, making sure your language concordant within the clinic as a key fundamental component, make sure that the sort of educational documents and literature that you're, providing are in Spanish, the help desk is in Spanish. So that's been key. And I think, in our community sites, we have a lot of community health workers and the registration staff are people from the community who are many of whom are monolingual Spanish speakers. And when we've done surveys, like language and friendly sort of welcoming environment is the top reason why people come to our site for testing. And so I think that is a critical piece. And then my third point is I think it's very important for all of us, I work at a university is really making sure that we continue to invest in the pathway of physicians, social workers, nurses from the communities most affected and who also bring language skills. And so I think that's a critical piece of training and ensuring sort of the diversity of the healthcare provider workforce. And that will help also with language and also this cultural concordance, and something I know we're all very excited about. So that's another area to think about for the future.
Thank you, Dr. Marquez. And definitely that's something that has helped. And I mean, in my practice, I have a lot of patients coming in because like you talk like me, you look like me, and that's why I'm here. And it's easy to build a rapport and they trust you. So having that in a clinic definitely helps a lot. PrEP, an amazing tool to prevent HIV transmission. It's been for many years, and we know that especially oral PrEP is up to 99% effective when taken daily. We have more options now, the long-acting injectables, on demand, for all populations, for everyone, right? Whoever wants PrEP, we're able to provide that now, right? There's no restriction, but it's something really good. When doing the HIV test, Leo, what are some ways that we can start that conversation even before providing that test? Trying to just, since we know PrEP is for all, so it's like, okay, you're HIV negative or you might be HIV negative. What's some ways that I can start that conversation, let's say as a social worker or as a therapist or anyone out in the community that's doing that test?
No, absolutely. That's such a great question because that's one of the big barriers that I think a lot of different organizations face is how do we start the conversation? How do we start the conversation with communities that, have a stigma against, we call it white coat stigma or, and it can be difficult. Honestly, I think the best way to start the conversation is to just be real about it. Have you heard about it? This is what it does. Not using elevated language to describe what it does, but really bringing it down to a pedestrian level. You know, I've heard people call it a shield. I've heard people call it a barrier. I've heard people call it all types of things just to get it across to the person that happens to be in front of them. And I think finding creative ways to do that with men, women, non-gender conforming individuals, young, old, Latin, Black, Asian, you know, whatever, you have to find those pockets where it's going to make sense for them in their head. And they may not get it that first time. So also having material that you can give them, also having, you know, posters in your offices, or pamphlets, palm cards that you can hang out that again are bringing it down to a very easy to understand, you know, level. They don't need fancy diagrams, you know, about cells and things like that. It just really needs to be accessible. And, you know, when we talk about language, when we talk about access, having it written for them so that they can understand it, coming from whatever educational background or whatever experience they have. So just really putting it into real, easy perspective so that when they go home, they can explain it to their girlfriend, their boyfriend, their mom, their dad, whatever have you. Honestly, I think that's the easiest way. And then there's no right or wrong way to kind of talk about PrEP depending on who you're talking to in those moments. Yeah, and it's going to change each and every time you have somebody different in front of you. What worked for Sally is not going to work for Jason, you know, so being creative with it.
Yeah, definitely having all those tools in place and just seeing the person that you have and doing that patient center model. So, you know, it's the person and this is what we're able to provide. And definitely letting them know that it's empowering them to take control of their health, right? Because they're HIV negative and they have something that they can do to remain HIV negative. And it's something, you know, really good to have that. Dr. Marquez, any story that you might have with PrEP that it's like someone came in that the HIV test was negative and you know left with PrEP? Any stories that you might have?
I think one story, I think based from our community-based settings and HIV testing, what we have we had people come in who may have never accessed HIV testing in San Francisco or the US before, and a lot of recent immigrants. And what we do is, you know, they also test for diabetes, another get blood pressure screen, and then we have community health workers who really are there to just, you know, just like Leo said, like, have you heard about PrEP? And one of the things that has been very helpful, I think, in our community-based sites is navigation. So sometimes it's just this permission to say, hey, is it okay if you know, people are contemplative. Is it okay if I give you a call to follow up? Or if someone's, you know, we had a patient who was expressed, you know, interest in learning more, and our navigator was like, hey, is it okay if I follow up? Or, you know, can you come to the clinic at, because I think that linkage between community and clinic is a little bit sometimes scary, can be sort of challenging or scary for some, and say, it's okay if we meet at the clinic so that we can help make sure you are able to access it. And those conversations are so exciting because people, I think some people will want navigation, some people won't. But we had a patient who was really excited. I think didn't realize that you know, that they could get some form of health insurance and get started on PrEP even though they didn't have health insurance at that time. And just the level of excitement, I think is just really, really exciting. And we got someone started on PrEP, I think within 3 days, which for us was great since we're testing on the weekend, and continuing to build that relationship through navigation. I think there's other sort of continuing to have, for some people, you know, a check-in. How's it going? Were you able to make your follow-up appointment? And answering other questions. So I think that was just one story, but I think that when you can link people who have never interacted with the you know, health system in San Francisco to care is really exciting. And I know Franco probably in City Clinic has similar experiences because it's a drop-in, you know, no insurance needed place. So it's why we're out there. It makes me very, very happy and why we do the work.
Yeah, that's really a great story. And I think, as an HIV specialist, those are the stories that make you happy. Having that person going out on PrEP and knowing that it's like, okay, that's one less person who's going to be HIV. So that's the way to end the HIV epidemic. Dr. Chevalier, any stories, anything that you're like, wow, this is why I love doing what I'm doing?
Yeah, totally. I mean, I have many. I think working at a sexual health clinic, there are so many stories that kind of cross my mind. But I think one of the most profound stories, it's not so much the context of the story itself, but I think the messaging that the patient sort of delivered to me afterwards. And this was a cisgender female patient that who is HIV negative, and lives and currently has an open relationship with her male partner who is living with HIV, undetectable, and was seeking PrEP, but due to lack of insurance, was basically trying to get on PrEP. Not so much because of the fear of contracting HIV from her partner, because her partner, again, is undetectable, which means that they are untransmittable. But given that they are open and they go to like swinger parties and things like that, she just wanted to have more of a proactive sort of approach to her sexual health. And so she got an injectable cabotegravir and has been coming in, reliably every 2 months, gets her PrEP, and she's been HIV negative for as long as I've been here. And one of the things that that we always ask is like, how do you feel? And one of the things that she says is that PrEP has allowed her to, in some ways, she thinks back about oral contraception, and she thinks about sort of like women's rights when it comes to like their bodies. And she said, in some ways, PrEP has given me a choice. And she says a choice really in the context of how I enjoy myself and how I view pleasure and sex and what I get to do with my body. And so that to me, is very profound because we don't think about it in the context of that. We think about it from the prevention perspective, but really, truly, we are impacting people's sexual experiences. We are really impacting people's experiences of how they sort of date, how they interact with people, what they get to do with their bodies and what they don't get to do. And so really, you are really getting into not just, the health aspect, but also the social components that oftentimes we tend to forget when it comes to the medical things that we do. And so for me, that's probably one of the best stories because it really fuels me and makes me go home happy thinking that I did something good. So I would say that that's probably one of the biggest, one of the stories that has really marked me since I've been here.
Thank you. And yeah, amazing, amazing story. So, this talk is for the participants, and we've shared a lot of experiences, a lot of best practices. So now I'll leave it open for any questions that the participants might have so we can answer. Is there any questions? Okay. Well, in the meantime that we get any questions, I do have one for you, Dr. Marquez. So starting PrEP, it's a process and we have those best practices. And I think we're doing really good as different clinics, organizations. But the retention, I think that's something that we've always been kind of lacking, or we're still not 100% sure or have the best practices. Something in your experience that you've tried or have best practices to trying to retain those people on PrEP?
Mm-hmm. Yeah, I think retention is the key. I think we've had, I think one common reason for retention challenges, or sometimes when I see patients off PrEP who want to be on PrEP, is insurance changes and not really figuring out how to navigate that system. So I think really in care transitions, making sure that there's a plan for patients is one major step. And I can think of many people who have new diagnoses of HIV who were on PrEP before but fell out of care because of insurance, or they changed jobs and their insurance changes. So I think that's something we have to be pretty particular about. And then I think thinking about things that have helped with retention is really just easing convenience. And so how quickly can you get people in to do, their follow-up visits and their tests? And then I think injectable PrEP for many has been something that's kind of kept people involved in PrEP. And so I think it's just the ease of coming every, at a regular schedule and not having to take a pill has been, I think, a game changer. So I think from a clinic standpoint, thinking about how we can arrange our clinic to be sort of easy access and to accommodate all the injections needed for injectable PrEP and long-acting ART, and making sure that those systems are in place, I think have been helpful. Navigation for some people is really helpful, or case management is another key thing. So to really try to address some of the other social determinants that are impacting their ability to stay in PrEP. So that has been, I think, a big success for many, from whether it's HIV or PrEP or Hep C. We have Hep C navigators are fantastic. So I think navigation for some is going to be key, or sometimes thinking about different incentive programs. And then also co-locating services, I think, is really, really nice. So it's great for you to be able to get your, estrogen injection and PrEP at the same time, and thinking about integrating, co-locating sort of those services all in the same place, I think helps patients stay to, lowers the barriers for engagement. So that's great.
Thank you. And Leo, so yeah, definitely there's multiple ways that we can try to have that HIV testing or PrEP. One question from the audience is, how can telehealth or other digital health tools assist in this space?
Oh, such a good question. And this reminds me of a doctor that I worked with when I was at my clinic in DC. His name is Dr. Ford, and he was animate about telehealth and PrEP. Because when we talk about access, sometimes the barrier is just getting, across town to said clinic. And so he set up a very successful teleprep service to where clients did not necessarily have to physically come into the office. They could report to like a LabCorp or whatever have you in their proximity. And then he would go over their results, and he would administer, PrEP via telehealth. And it made a world of difference for clients that worked outside of, clinic hours, for clients that did not necessarily have transportation. It's definitely possible. It's just kind of putting those resources together to make it happen.
Thank you. Yeah, definitely. I think telehealth, since COVID has helped in many medical care needs, and with HIV PrEP, I feel it's something that has really helped. And there's multiple telehealth clinics or providers out there in the U.S., so it's something that has really, really helped. So the other is for DoxyPEP, and then Dr. Chevalier. So, when someone comes in and it's coming in for HIV PrEP, what are some ways that you kind of address also that accessibility of DoxyPEP as, as an ID specialist or as a primary care provider?
Yeah, that's a great question. And very, very timely in many ways. One, because the CDC just recently published their guidelines around DoxyPEP, and sort of, some advice for primary care physicians or for anyone who wants to really truly prescribe it, that could prescribe it. And then also just recently got back from DC at the STI Engage and Sync 2024 conferences, where a lot of the discussions were about sort of like, how do we approach this from a syndemic perspective? How do we introduce DoxyPEP? How do we sort of, reduce the risk of STIs and all of that, and the burden of STIs? And I think first and foremost, if any patient, and if you're a provider out there, if any patient is seeking PrEP or is on PrEP and you have not introduced DoxyPEP to them, then, next time that they step into your office, that should be the time to do so, because I think that 2 and 2 go hand in hand together, because there is a lot of misconceptions, and there's been a reduced uptake in resistance also in some areas about DoxyPEP, but I do think that it's such a great tool that everyone should be accessing. But I think first and foremost also is really looking at the infrastructure of how to support that program for everyone, because I think equity is going to be the big thing too, from the perspective of how do we make sure that everyone across the board, across the nation, whether they're rural or urban, whether it is a municipal clinic versus a private insurance person, how are they able to access this medication? And so really thinking about how to support programs and infrastructures from a policy level, from a national level and local level, so that we can actually have those resources available for patients and make it mainstream for them. But also, again, just normalizing the conversations around it, and also just emphasizing all the risks and benefits. I think that a lot of people tend to have resistance because we always try to introduce things from a positive perspective, like, oh, this is great. But I think that patients really appreciate when you also say, this is what we don't know, and this is what we know, because then again, it's that context of empowerment, that context of feeling like they're taking ownership of their health, and that they too also play a choice in what they take and what they choose not to take. But also opens the door for more conversations and more retention in that matter as well. So many things also that could be added to that. But I think that's a good sort of summary of how we can potentially improve accessibility.
If I can add a few quick thoughts, because I think that was so beautiful. I want to even just talk about some of the provider level, like just simple systems level things as like in your day-to-day environment as a clinician that I think have helped me. And one is thinking about other people, we have, when people come in for treatment for gonorrhea or chlamydia for after a positive STI test, the nurse gives a shot for gonorrhea and actually talks about DoxyPEP. Oh, have you heard about DoxyPEP? And then I get a little message, hey, so-and-so is interested in DoxyPEP, and then I can send it on. So I think that having other people being equipped to, besides physicians, being able to talk about DoxyPEP in a systematic way is really helpful. Even little things like having a program dot phrase with like the DoxyPEP things that you need to discuss about how frequently they should still test for STIs, how to take doxycycline, and have that sort of really easy for the clinician has been helpful. And then the third thing is we even put in within our Epic, for those who work in Epic, like a specific, you just type DoxyPEP, and then it pops up exactly how you need to prescribe DoxyPEP with the instructions for the patient, and that goes to the pharmacy. And those little things I think help busy clinicians prescribe DoxyPEP. They're small, but I appreciate them as a provider.
Yeah, those are definitely great tools, and simplifying things help everyone, and having all the staff around knowing what it is also helps, because a patient, he might not trust you as much as, let's say, the medical assistant or a nurse. And if a nurse talks to them about DoxyPEP, then they'll be like, okay, I have more rapport with you. Let me talk with my provider, with my doctor, and see if it's something that will be good for me. But yes, those are really, really good tools. And thank you for the three of you. I mean, amazing. Your vast experience definitely just is incredible. And I think together is ending the HIV epidemic. And, the first step of ending this epidemic, it's doing the HIV test, is having that person know what their HIV status is. And it's not just ending it there, as you heard today. It's all those extra tools that we have. If they're HIV positive, U equals U, it's a powerful tool. And then if they're HIV negative, PrEP, PEP, DoxyPEP, all those tools that we have to reduce HIV transmission. And I'm sure that together we'll be able to end this HIV epidemic. Okay, and then to the next slide. So CDC campaigns material. This is the roadmap to become undetectable, because if we know U equals U, and to get that HIV test is knowing, and then also knowing what your risks are. So it's really, really important. And this is a CDC campaign that has been going on, and it's I encourage everyone to visit this website and learn about HIV. How can we prevent that HIV transmission when someone is already HIV positive? And then more upcoming events. We do have an Instagram Live on June 27, which is National HIV Testing Day. So that's a community-based approach to stigma and treatment. Also, July 9th, there's a Zoom meeting for exploring clinical trials and cancer screenings. And then June 16, we have a medical school roundtable for HIV treatment and careers. We do need more HIV specialists. And, as a family medicine, it's a passion of me also being an HIV specialist. So there's many ways that you can contribute in becoming an HIV specialist. And definitely follow us on social media. There's multiple materials that will help you, not just with HIV, but also other materials that are for medical care and more focused on our Latino population. Okay, and then definitely empowering Hispanic health. All right, thank you everyone, and I hope this was beneficial for you.